All right, let's hear a little bit about refractive and presbyopic treatment. So we bring up John Hovhanessian, someone known to all of us.
Thanks, Eric, and thanks everyone for staying for the best session at ASCRS. And I picked 3 papers from the best of the refractive section because I thought they were quite relevant. And starting with one from Jan Ventnor in the UK about clinical and patient-reported outcomes of different combinations of diffractive and EDOF lenses. We can advance. There we go. We got twice. So this was retrospective data from Optical Express, and what was most intriguing about it to me is the numbers of patients. If you look at the bottom, we've got several thousand, about 3,000 patients with Symphony, with a mixture of, and those Symphony were primarily aiming for mini monovision. That's important when we look at the results. And we've got lower numbers, but still quite significant for other combinations of these, in this case, AMO lenses. And the different groups of patients that are included here were all fairly comparable in terms of vision and age and other parameters preoperatively. And there were some interesting trends that were seen. First, in terms of uncorrected distance vision, there were statistically significant differences here, with the highest rate of uncorrected distance vision being among those who had the 275 ad Technis multifocal lens, and lower, of course, in the Symphony group, which had mini monovision. Similarly, we saw uncorrected near vision that was statistically better in the 275 bilateral group, or best there, and with Symphony combined with a 3.25 diopter ad, higher ad Technis multifocal. And then lowest with the mini mono in the Symphony group. Among other results here, manifest spherical equivalent was less on target in the Symphony group because, of course, it was mini monovision, so that's kind of an apples to oranges comparison. Patient satisfaction, looking overall, was tended to favor those patients in the higher ad lens group, and this a little bit surprised me, and in the group that had the mix and match between the Symphony and the 3.25 diopter ad lens. Glare and halos were worse in this case with the mini monovision Symphony group, significantly worse than they were with the other combinations with higher ad Technis lenses. So panel, tell me how this squares with your experience. They concluded that the higher ad lens seemed to be the most preferred by patients, but tell me how this, tell me your thoughts.
Let's start with Ed Manchis.
Could you go back a slide?
Sure.
So they're reporting moderate to severe halos in almost a quarter of the time.
With the mini monovision with Symphony in this case. And again, this is patient reported from a large data set in the UK.
But even in the other,
on the FDA, pardon?
Even in the other groups, it's still 20%.
Yeah, it's higher. Yeah.
So that seems higher to me than what we've been told. I mean, or is that your experience?
So we actually collected, this is not my data, of course, this is from the UK, I'm presenting their paper, but we found less than this among our patients with Symphony. We do a lot of data collection on patient experience, but in any case, this is what they're finding. I think what I'd highlight here is, because we don't have exactly the wording of the questionnaire, yeah. We don't have if they had images, and there's a lot of nuance to the way questions are asked about patient psychometric instruments, but the difference is what I think you can count on. And in this case, it is statistically different.
So you have really 2 opportunities with presbyopic IOLs. You can do bilateral, or you can do mixing with a Symphony generally in the dominant eye and a 325 in the non-dominant. Kerry Solomon and myself wrote a paper where we did mini monovision with the Symphony. So you gave him plano and minus a half in the other eye, feeling that minus a half would give you extra reading. But the net result of it was, while you did get more reading, the quality of vision at distance as a minus a half wasn't as good. So we've stopped doing that. We just now do, if we want to give someone more reading with the EDOF lens, we do the 325. So a 325 geared for distance will give you as much reading, but you don't degrade the distance as much. So that's something that we're doing more and more of.
Interestingly, each lens platform is different. We just are publishing a paper now with the Alcon platform. So the low-ad 2.5 diopter mixed and matched with the 3.0 had significantly less glare than we had with the bilateral 3.0, and we also are now publishing 2.5 mini monovision. And in that case, we had less glare also than the higher-ad lenses. So, they're not exactly the same kind of design, even though they have, an EDOF and a low-ad multifocal are theoretically in the same category. They're not quite the same. So
let's go to Oliver and then David.
I think we see that if you use an EDOF lens and you have one eye aimed for minus and you actually achieve minus 0.75, for example, that's micromonovision, that the halos tend to be stronger and the glare maybe as well. Right. So I think it's really the defocused eye which is causing the trouble, which we don't have so much in standard monovision with a monofocal lens, because there it's a different situation. So I think that's what you're seeing here. I'm actually astonished in the UK that they're not using trifocal lenses. Obviously, this is also a study of the past, because it's a retrospective study. But it's something which, to be honest, in the European market, bifocal lenses have essentially disappeared.
In Europe, what percentage of patients are receiving EDOF versus trifocals now?
I would say trifocal is at least 2/3.
We'll have trifocals coming the end of this year, so we're looking forward to that. David.
Yeah, one takeaway is all of these work, but I think we are seeing that with the Symphony, self-reported nighttime image is actually higher than some of the multifocals, and that's why the highest group in terms of starburst was bilateral Symphony. But then of course there's a trade-off with contrast sensitivity. So kind of how you word the questionnaire is very important. I don't know that any of these differences are that significant, given the bias that can be built into a questionnaire.
Okay, let's go.
There's certainly large numbers. Moving on to the next paper. I'm not able to advance here. Here we go. So this was an interesting study from Shadi Awad from Beirut, and about looking at intraoperative OCT as a way to measure post-op or to predict post-op ICL vault in patients receiving this phakic IOL. I thought this was interesting largely because we are on the verge of getting intraoperative OCT here in the U.S., but don't yet, and I don't think we've fully realized all the benefits it could give us. But here's a case where it might. Predicting what size ICL to put in an eye is currently done based on the white-to-white diameter, and it's really not highly accurate. There's a bunch of variables, including internal anatomy, that can cause a lens to vault more or vault less. So in this study, which was done prospectively, they had 42 eyes of 24 patients, and they did intraoperative OCT and then compared that to what post-op OCT showed in the ICL vault at a variety of days going out to day 90. And, so with both instruments, including intraop at the bottom, you can get a nice clear image of how far off the surface of the crystalline lens the ICL sits. The upper part of each image there is the ICL myopic lens contour that you see. And so in surgery, this is lined up with the eye, and one can get an image that can guide us and let us know whether the vault is desirable or not, presumably replace the lens if we're concerned. Now, naturally, viscoelastic in the eye alters the lens vault, and consistently the authors saw a decrease in the vault when viscoelastic was removed. And then postoperatively, going from the first data point onward, there's a little bit of decrease in lens vault over these first 3 months. Which has been also seen in other studies. And then, of course, as a patient ages, their lens thickness grows by about 25 microns per year, and so that vaulting tends to become less over time. Here's what I thought was most interesting. So this is looking at the difference between intraoperative and postoperative measurement of lens vault, and they found fairly good correlation, although the intraoperative measurement predictably measured 100 microns greater vault than they got in post-op measurements. So we don't want too thin a vault because it will allow cataract to form. We don't want too thick because that means the lens is pressing into the ciliary sulcus and potentially causing chafing or even corneal endothelial damage. And we may, if we can measure intraoperatively, have a better idea exactly what lens to open before we actually implant the lens. So panel, tell us your thoughts on intraoperative OCT.
Well, I think one issue about intraoperative OCT, I mean, we've been using it since many years, we had the prototype, is that actually with the model he's using, I guess that was a rescan 700 by Zeiss, you actually don't get a measurement. That means you have to do these measurements afterwards in post-processing. And you don't actually know how much a pixel is in millimeters or in micrometers. So that means he has to do some kind of extrapolation because actually DICE doesn't give you the data. In the new software they do, so that has changed now. But I think that's one of the issues which you have to keep in mind in this setting. And the other one is, you saw that it was a little thicker, like 100 microns on average.
Yeah.
That can be obviously viscoelastic. It can also be because the pupil is still huge and very dilated, because we know that when the pupil comes down, it does seem to press the ICL back a little. There's a nice study which was presented at ESCRS last year about that. So I think these are issues which you don't have on the table. But I think it's nice, it's neat. I think it's...
I'll ask a general question to you, Oliver, and that is in the United States we've had ICL for a long time, but we don't have the new lens with the hole in the center to allow fluid to exchange. Okay? We've had problems in that the ICL works very nicely. It's very good for high myopes who aren't good candidates for LASIK or SMILE, but there's a pretty high incidence of cataracts associated with them over time. Has that hole in the middle resolved that problem?
So they call it aquaport.
Okay.
It's a very, very small hole right in the center, and I mean, we don't have it since that many years. I think now it's 3 or 4 years since we have the aquaport. And I believe that has really reduced the risk of cataract significantly. But there's one thing you have to watch out for, and actually Thomas Conan showed a very nice paper and presented that. If you try to remove the viscoelastic through the aquaport, by trying to essentially irrigate through the port to get the viscoelastic from the space between ICL and lens away, you can actually get cataracts just by doing that intraoperatively or just postoperatively, so anterior capsule pacification. So you should not use the port for flushing. That's what I'm trying to say.
Great. All right, let's go.
Well, and the third paper I picked was an interesting modification of topo-guided LASIK by Mark Lobanoff in Minneapolis. So topography-guided LASIK is based on the principle that an image of the front surface of the cornea can guide our laser ablation to theoretically get greater accuracy. The challenge is that the recommended tolerances for difference between topographic measured astigmatism and refractive is that we have very tight tolerances between them. And so only about 10% of patients in the FDA trial of the Contura laser were actually able to receive it, of those patients screened because of these tight tolerances. And then in actual practice, treating off of the MRX, manifest refraction, achieved visual acuities that were not as good as were achieved in the FDA trials. So what was hoped for was a mathematical model of taking the information from surface topography, putting it together with other information from refraction, and coming up with a nomogram for treating with laser that would actually improve visual acuity and give consistent results. So Mark has created a software called Forcities that purports to do this, and what it essentially does is borrow some logic from geographic imaging software where highs and lows are measured and determined for what the important elements are that would in this case affect focus of the eye, and then distill those high and low points into information that could be put into sort of a vector treatment of astigmatism, customizing the astigmatism and irregularity treatment with the laser. So this concept called TCN, or where a topographic contribution, a change in cylinder contribution, and a nomogram contribution are all factored together, along with adjusting for spherical equivalent. We won't go into all the details here, but the idea is to take that information from topography and use a simple nomogram that will, in a sophisticated way, take advantage of what we know from topography to give the patient a better outcome. In the end, 1 month results looking at a number of patients treated this way found that if you look at column 3 here, that's the yellow column, this is patients treated with the Forcities nomogram, and we're looking at what percentage of patients achieved each level of visual acuity. On the left is, of course, the FDA study of Contura. So with Forcities, they were able to match the consistent delivery of vision to what was found in the FDA study of Contura. So a pleasing result in a greater number of patients. And in some clinical practices, similarly, we were able to achieve high levels of 20/20 or even 20/15 vision, and this is reproducible across a couple of different practices that the authors shared with the audience in this presentation. So the idea is that this software will allow us to take the engine of topographic guided ablation and pair it with some math that allows better accuracy for treatment.
Can you go back to the picture of the topography there for me, please? So we've been using this as well. I think this has been a very significant improvement for regular patients who have refractive error. Leave it there, that's great. this applies, but if you're operating on keratoconic eyes, it's even more of an important issue because they're so irregular. But when you do a refraction, you're getting the actual refraction. When you're getting rid of the high-order aberrations by treating the irregularities, such as in this case, this is really a case of trefoil. You can see 3 hot spots in the periphery. What this is going to do is this is going to induce hyperopia. So, I'm sorry, this will be a hyperopic ablation, which would induce myopia. So what you're seeing here is an ablation profile that's going to change the refraction. Unless you account for that in your new nomogram, you're going to be off on your refractive error. So this here is going to make the patient actually more myopic, which would mean that you need to actually treat more and at a different axis. So this is really a very nice advance in managing topographic ablations that we haven't had before.
Since '95, when these lasers were first released, we have told patients wait for the future when we have the ability to treat irregular corneas, right, Ed? We were in fellowship around the same time in the same place, and now we may be closer to that.
Yeah, I think this is a real step forward. I think one of the problems, at least unique to the Wavelight platform, is that there was no standardized way of doing it. You'd talk to 3 different people, and they tell you to do it 3 different ways. If you talk to John Catanopoulos, you leave puzzled at the end because he has a complicated way to do it. But even the clinical application specialist from Alcon, if you had 2 different people, they would tell you 2 different ways. And I think if we can get standardization where we can treat more of these patients rather than 10%, it is a powerful tool, not only for highly aberrated eyes, but also for naturally occurring refractive error.
Yeah, so for patients who are coming in now who have keratoconus, for example, we've done hundreds of cases like this, and it's really very gratifying that you can treat an irregular cornea. A patient with keratoconus, you can take an abnormal cornea, cross-link it, and then do a topographic ablation, and then do cataract surgery, and take them from best corrected before they had a cataract, 2050, to uncorrected of 2025 or 2030. So I think it's a very exciting area, and this is just not for corneal surgeons. This really applies to cataract surgeons as well. You can start thinking about doing some things we didn't do in the past.
Great, that's it.
Any other comments? Great. Well, John Hovhanessian, thank you very much.
Eric has to leave, and a big round of applause for Eric Donenfeld. Always. For years, he's run this session. He always stays to the end. He does so much great work for the organization. Safe travels, Eric. Thank you.